Hi, good evening. This is Shay Cunningham. Thank you so much for joining me tonight as we discuss the health belief model. We are going to talk briefly about what it is, the constructs, the practical application, as well as the strengths and limitations thereof. I also first want to preface all of this saying if you hear a cat screaming, I actually have one just right behind that door. She's okay. She's just experiencing a little separation anxiety. So I do want to say no animals were hurt during the production of this video. So we're all okay there. But the reason why we're here, the health belief model. So a health belief model was developed out of behavioral and cognitive psychology. So when we go through this model, we are going to see a lot of influences from Watson, Skinner, Bandura woven throughout this model. And it rose out of the need for tuberculosis testing, screening in the 1950s. So there was lots of avenues for people to get tested. However, people were not getting screened. And so this is when the health belief model came to being. It is probably the most widely used model in health education and promotion. It's very highly individualized, and it's great at predicting behavior as well as explaining behavior, and we'll look at that throughout the constructs. I'm going to go through the 6 constructs, and I'm also going to weave in a practical application. Like I said, this is really great for explaining behavior, and it's also, this model is used for a lot of disease prevention. And so I'm going to use this model in reference to prevention of COVID-19. So as I go through the constructs, I will also give an example of how COVID-19 prevention is applicable to that. Okay, so we're going to first start off with first construct, which is perceived susceptibility. So perceived susceptibility is just that. It is your likelihood that you think that you will get a disease or illness. It's essentially your vulnerability. So when we talk about it in light of COVID-19, it's, am I going to get COVID? So that is really the first construct in a nutshell. Second one is perceived severity. And I really want to emphasize too that as we go throughout, we're going to hear perceived, right? It's the perception. So it is that individual's belief, their viewpoint. So again, perceived severity. It looks at the consequences of the disease, illness, or behavior. And I want to emphasize that this is not necessarily physical. So it can also be psychosocial or financial. So an example as it relates to COVID-19, it could be if I get COVID, I may end up in the hospital. So that could very much be a perceived severity application. It could also be if I get COVID, I'm going to miss work, which is a financial application of perceived severity. Another one, if I get COVID, who will take care of my children? So then we have that psychosocial component as well. So it's not just a physical severity, such as I may die if I get COVID. So there is that distinction there. The third is perceived barriers. And this is what is preventing an individual from changing their behavior. And similar to perceived severity, this can be physical, psychosocial, or financial. So in relationship to COVID-19, it's, I may want to get the vaccine, but I don't really like shots, and I want to do a more holistic approach. I want to get the vaccine, however, I don't really trust it. I don't think there's been enough research done. There also may be barriers when we talk about COVID-19, the vaccine, that some people may not have been able to access that resource. So there may be that actual physical limitation due to where they live or the ability to go and get the actual vaccine. Another barrier. Another barrier would be, in terms of finances, would be the expense of masks. So somebody may be like, well, I really do want to take precautions. I want to wear a mask. However, I can't afford to keep purchasing mask, or they're recommending N95s, and I don't have that kind of money to spend. So, or you can't even get to them. There was that time too when we couldn't find masks. So that's the third. Fourth is perceived benefits. So fourth construct. So these are the positive components or aspects or advantages of changing the behavior. Again, highly individualized. An example would be if I get vaccinated, I lower my risk to being hospitalized. And then, of course, you have to believe in this scenario that the vaccine is effective. And then also, if I get vaccinated, then I can live as much of a normal life as possible in COVID era. So I can travel. I can get into restaurants that have a mask mandate. So that's an application of the perceived benefits. The fifth construct of the health belief model is cues to action, and this is what encourages us to change our behavior. It can be an event, it can be a person. So for example, a friend or family member may be hospitalized because of COVID-19, and so that may encourage an individual to go out and get vaccinated and take more proper precautions, such as wearing masks when they're out and social distancing. Another one is your favorite athlete or your mentor may be advocating for vaccinations, so you also will then go out and get vaccinated. Right now there's a commercial out I saw, and I think it has like Questlove, Michael Phelps, Pink, and Kim Cattrall, and they're all advocating and promoting vaccinations. So that's also something that would cue an individual to going to and getting vaccinated. Another cue to action in regards to COVID-19 prevention would be your job requires it. So if your job is like, nope, you have to get vaccinated in order to stay here, and most people may get vaccinated. So that's also an aspect of it. Okay, so our final construct is self-efficacy. This is straight out of Bandura's social learning theory. This came into the health belief model later. It was added in 1988. And so I call this the little engine that could construct, because it's I think I can. So this is the confidence that an individual has that they will change that behavior. So it is, I can get vaccinated, I can wear a mask, I can maintain social distancing when I'm out in public. So that is examples of self-efficacy in the health belief model. We're now on to the strengths and weaknesses of the health belief model. As I mentioned before, it is a great tool in predicting behavior change, predicting behavior as well as explaining behavior. There's also a lot of modifiable factors and variables that are already woven into the health belief model. So it takes into account demographics such as gender, geographic location, sexual identity. So these are things that are within the constructs of the health belief model. It's also specific and narrow in focus, so it is highly individualized. And Also, you don't have to use all of the constructs. You can kind of pick and choose during needs assessment which one is best suited for your priority population. The limitations, there's not a lot of known data and understanding. We need to better understand the relationship and correlationship between the constructs and within them. And then we also need more research on the constructs of cue to action and self-efficacy. So as I leave you this evening, I want to encourage practical application in your life of the health belief model. And when I was thinking, like, how can I use this in my everyday? For me, I encourage you to think about your sleep routine. So as we think of proper sleep hygiene, so all of us have a million things to do, but we know that sleep is not always best. With our phones and our computers and our tablets always right there in front of us, and so many distractions of life. So how can you apply these various constructs to getting better sleep? And if you're getting great sleep, and if you're not susceptible to this, congratulations. But I would encourage you to look at your barriers, look at your susceptibility, and the severity especially. So thank you all for listening. I appreciate it and look forward to our next theory. Good night.